latent screw removal under general anesthesia. Her previous surgery for the clavicle fixation was uneventful. The induction of anesthesia was achieved with 100 mg propofol, and endotracheal intubation was facilitated with 30 mg of rocuronium. And the surgery lasted for nearly 1 hour. Residual muscle paralysis was reversed with appropriate dose of neostigmine 2.5 mg and glycopyrrolate 0.4. Inhalation agents were turned off. After thorough suctioning of the oral cavity under direct vision, the patient was extubated. Few minutes later, we found that the patient became restless, had jerky movements, and was complaining about she was not able to breathe. What could be the possible reasons? Any postgraduates? I mean, more or less straightforward, restless, couldn't breathe, jerky movements. It's residual muscle paralysis. The most appropriate definition for the residual neuromuscular blockade is a Travancore ratio more than 0.9 and results from incomplete reversal after the neuromuscular blockade administration. So, two things are very important: a Travancore ratio Travancore ratio less than 0.9 and incomplete reversal after a neuromuscular blockade. The reported incidence of residual neuromuscular blockade is around 40 to 65% as per the literature in patients being administered non-depolarizing muscle relaxants. For the non-abdomen surgeries, we usually perform the surgeries if you use a neuromuscular monitoring with a TOF count less than around 1 or 2. And for the major abdomen surgeries, we need a much deeper level of blockade, where we used to have a TOF ratio of TOF count of no twitches or a PTC of 1 to 2 during the surgery. So, what are the causes of residual neuromuscular blockades? Multifactorial, but I would like to stick to 2 of them. As you all know, including me, we are all fond of administering neuromuscular blockades based on a time-based pattern. Our PGs, me, everybody administer. If it is a neurosurgical cases, we used to give neuromuscular blockades every 20 minutes. We don't wait for any patient to come out of the previous neuromuscular blockade drug. So, it's a time-based administration. So, most of the time, at the time of extubation or end of the surgeries, your patients might be in a profound depth of neuromuscular blockade. And the second thing is reversal agent administered not based on dose or time. We don't monitor, so we might be reversing the patient in a deeper level of block or a moderate level of block. And the dose also, in a deeper level of block, the dose might be different. In a shallow block, the dose might be different. So, for the appropriate reversal of neuromuscular blockade, your neuromuscular blocking agent dose, your neuromuscular blockade reversal agent dose, and an appropriate, especially a quantitative neuromuscular monitoring is necessary. So, despite numerous advances in anesthetic drugs, techniques, monitoring, still the use of neuromuscular blocking drugs increases the morbidity and mortality. The morbidity is basically because of impairment of the laryngeal reflexes and swallowing function, and also impairment of the hypoxic respiratory drive, because the neuromuscular blocking agents can depress the chemoreceptor body and lead to decreased response to hypoxia or hypercarbia. And studies have been shown that residual neuromuscular blocks have been directly linked to increased risk of pulmonary complications. So, how do we exterminate the residual neuromuscular blockade? On this outset, I would like to go to a drug which mostly you people are also using. We are generously using, even though I just want to use it judiciously, but unfortunately we are generously using this drug Sugammadex. So, let us talk about a few points about Sugammadex. You can use any name. It is the first reversal binding agent, it is a chelating agent, or it is a direct direct reversal agent, whichever name you can use. And it is a gamma cyclodextrin consisting of an oligosaccharide linked around a central cavity. It got a very short onset of 1 to 2 minutes and a half-life of 2 hours, excreted generously through the kidneys, not metabolized in the body. So, it does not depend upon any organ function, and it is independent of pH and temperature also. So, a wonder drug, I would say a wonder drug. And the mechanism of action is it acts against the aminosteroid group of muscle relaxants, and those aminosteroid groups of the muscle relaxants, especially against rocuronium. I will come to that later. So these aminosteroidal neuromuscular agents get entrapped within this cavity of the oligosaccharide gamma cyclodextrin Sugammadex, neutralizing the relaxant and thereby decreasing the plasma level and creating a concentration gradient which facilitates the movement of the rocuronium from the neuromuscular junction to the plasma, where those things are again neutralized. So I just go to the dosing schedule if you are having a quantitative neuromuscular blocking monitoring facility. If Sugammadex is using for reversal of neuromuscular blockade, you use a quantitative neuromuscular blocking agent, you do a train of 4 count. And if your train of 4 count is 4, then naturally you can look for the train of 4 ratio. And if the train of 4 ratio is 0.9 or more than 0.9, then there is no need to administer Sugammadex. And if the train of 4 ratio is between 0.4 and 0.9, you should be administering a dose of 2 mg per kg. And if the TOF count is 2 or 3, and definitely your train of 4 ratio can't be measured, and even if you're measuring, it will be definitely less than 0.9. Again, you can use a dose of 2 mg per kg. But if the TOF count is 1 or 2 or 0, or the PTC is 1, you have to use a dose of 4 mg per kg. And if the TOF count is also 0, PTC is also 0, you can definitely use a dose of 16 mg per kg, and the onset is within 1 to 2 minutes. And if there is no peripheral nerve stimulator, you definitely, you can't go for a train of 4 ratio. Then you look at the train of 4 count, 1 to 2 count, no fade or fade, you can use 2 mg per kg, 2 mg per kg. Train of 4 ratio count is 1, PTC 1. That means your patient is in a deeper level of block or profound level of block, you have to use 4 mg per kg. And if there is no response to any kind of stimulus, you have to administer 16 mg per kg. And we do have experience. We were forced to give a 16 mg per kg dose for a pediatric patient posted for foreign body removal. Unfortunately, the gastrosurgeon put the scope and said that, sir, the foreign body is not seen. And we had given the drugs around 3 minutes back, and as Sugammadex was available, straight away we had given 16 mg per kg, and within 2 minutes patient is out of neuromuscular blockade, but we take another 5-10 minutes because they have to come out of the effect of the anesthetic drug also. So this is about regarding the dosing. One more slide. If you are using double burst stimulation, if you are getting two teachers of the double burst stimulation or two counts of the train of 4 ratio, a train of 4 count, you can use a dose of 2 mg per kg, and if there is no response to any nerve stimulation, the dose should be 4 mg, and for emergency purpose, you can use 16 mg per kg. That's regarding the dosing. Coming to the clinical efficacy, the STRONGER trial of 2020 has shown that it got superior reversal capacity over the drugs we commonly use, neostigmine. The response are due to the rapid recovery, effective even in a deeper level of block where you can give 4 mg per kg, and for the immediate reversal, you can use 16 mg per kg, enabling faster operating room turnover. We generously, I said generously, even though I want it judiciously, generously using, because it helps us to overcome the turnover time. Usually the turnover time may increase from 20 minutes to 41 hour. But after Sugammadex, we started using Sugammadex, the operating room turnover time significantly came down. Within 15-20 minutes, we were able to take the next case, and the risk of residual neuromuscular blockade is also less. A few points about pediatric population. I forgot to say, Sugammadex was given FDA approval in 2015, but it got FDA, at that point of time, it was approved only for the adult population against aminosteroidal neuromuscular blockade. By 2020-21, FDA had given approval for pediatric age group 2 years and above, but not below 2 years. Below 2 years, it's still an off-label use. Why it is still an off-label use is because in pediatric patients, you all might be knowing, their neuromuscular junction response to neuromuscular blockades is extremely different from the adults due to multiple reasons. Immature neuromuscular receptors, neuromuscular junction and receptors, their extracellular composition, their anatomy, respiratory physiology, muscle mass, whatever, pharmacokinetics, hepatic and renal systems are not properly functional, and their neuromuscular receptors are highly sensitive to neuromuscular blocking agents. So if you are using, it's an off-label use, if you are using for pediatric age group less than 2, you should be prepared to manage the possibility of a recurrentization, and a dose dose-dependent bradycardia or some hypersensitivity reactions. The safety profile, as I said, bradycardia. The previous slide regarding Sugammadex, it was mentioned that hypotension, tachycardia, yes, sometimes because of anaphylaxis, you might get tachycardia, but mainly it's because it's bradycardia, because when you reverse the neuromuscular blockade with Sugammadex, naturally the muscle relaxants will be pulled away from the neuromuscular junction or the receptors, and acetylcholine will be coming back and acting on the nicotinic acetylcholine receptors, so as they will be acting on the muscarinic receptors also. So probably the bradycardia might be due to the excess action of acetylcholine in the muscarinic acetylcholine receptors, but it is responsive to atropine. Hypersensitivity, the incident is 0.02 to 0.3 only, so need not have to worry about such a huge risk of anaphylaxis and all those things. There is a consideration in patients with renal dysfunction, because the Sugammadex is basically excreted unchanged through the kidney. In a normal patients with a normal renal function, 90% of the dose will be excreted via kidney within 24 hours. But in patients with renal dysfunctions, the half-life, which is 2 hours in normal patients, can get prolonged to 4 hours, 6 hours, 19 hours in mild, moderate and severe renal dysfunction. So there is a possibility of recurrentization in patients with severe renal dysfunction, because the association between Sugammadex and rocuronium is very strong. The affinity constant of rocuronium for Sugammadex is around 25 million, which is 2.5 times greater than the association between vecuronium and Sugammadex. So a tight bondage is formed, but Sugammadex is basically excreted via kidney. There is a theoretical possibility of the recurrentization which can happen. So just be cautious if you are using for patients with severe renal dysfunction, but the literature has shown against it, because a 2024 article which was published in Anesthesia Analgesia, they compared the efficacy of Sugammadex and neostigmine in patients with renal dysfunction, and they found that when Sugammadex was administered, the return to turnover ratio more than 0.9 was much faster with Sugammadex compared to neostigmine. So it's just, I feel that it might be a theoretical concern. Better, larger studies have to be come. Again, if you are so worried about this theoretical dysfunction, the options are you can use cis atracurium, which is not reversed by Sugammadex, and wait for the patients to come out of the muscle relaxants. However, the bondage between Sugammadex and rocuronium, as I said, it is 25 million, the constant is 25 million, and the dissociation is, the association is very strong because of the van der Waals forces, hydrogen bonding and hydrophilic interactions. The chance for dissociation is perhaps very less. Of the 25 million molecules bound together, one molecule might get dissociated. So I feel we can safely use in even patients with severe renal dysfunction, and in centers where renal transplant are conducted, they are also using Sugammadex judiciously. And drug interaction, being a steroidal compound, it got interaction with progesterone, and if your patients are taking oral contraceptives for contraceptive purpose, make sure after Sugammadex for the next 7 days your patients are having another source of contraceptive measures. Otherwise, there could be a possibility of contraception because there is an interaction between progesterone and Sugammadex. Coming back to the pregnancy, again pregnancy, as I said, Sugammadex got an interaction with progesterone. It decreases the amount of progesterone. Progesterone is very vital to maintain pregnancy. So there could be a possibility of preterm or preterm labor or premature rupture of membrane. Again, it is a theoretical concern, and latest one letter to editor which published in Anesthesia Patient Safety Foundation, the authors they don't feel that a blanket recommendation to avoid Sugammadex in pregnancy is not in the best interest of the patients. That's in pregnancy. If you are giving general anesthesia for C-section, you can safely use Sugammadex, because safely use Sugammadex, especially if you feel that there is a situation where there is can't intubate, can't ventilation situation, hypoxia should be given weightage over the possibility of Sugammadex causing complications. Lactation, there's a little bit concerns about lactation. It can get secreted into the breast milk, but Sugammadex molecules are quite large and polarized, so very little is being transferred to the breast milk. The bioavailability is also very low. So again, it's a theoretical concern. Lactation is a problem. I feel you can safely use either in pregnancy and lactation. Cost effectiveness, everybody will be worried. Neostigmine, 1 ampule cost I think around 7 rupees, and the Sugammadex we use cost around 850 rupees. But again, while costlier than Neostigmine, analysis suggests cost saving from shorter recovery time and reduced complications. Complications used to the reduced residual neuromuscular blockade. Special population in obesity, dosing is actually based on the actual body weight, but there could be adjustment like ideal weight, ideal dose plus a 40% extra can be used in patients who is having morbid obesity. Emergency use, definitely 16 mg per kg. Your patient will be out of neuromuscular muscular relaxants within 1 to 2 minutes. New research and guidelines recommends ASA practice guidelines for monitoring and antagonism of neuromuscular blockade suggest that a quantitative, not a qualitative, a quantitative neuromuscular monitoring facility should be used not just to dose but to time to avoid residual neuromuscular paralysis. There is environmental concerns being cyclodextrin, they are biodegradable but go through the product information regarding the disposal protocols. Now, you had given rocuronium and reversed your patient with Sugammadex. Unfortunately, your patient is having laryngospasm. What are your options? In a scenario where the patient developed laryngospasm after reversal, your options are Sugammadex binds with rocuronium in a 1:1 ratio. So, whatever rocuronium you are giving, that can rapidly get inactivated by the Sugammadex in the circulation. So, if rocuronium is re-administered immediately after Sugammadex, residual Sugammadex in the bloodstream may bind to the new dose, reducing its efficacy. The half-life is 2 hours, so the Sugammadex can persist in the circulation for a longer period of time. So, what is the preferred agent? Succinylcholine, our good old succinylcholine is the first choice drug which will act in 30 to 60 minutes, but make sure your patient doesn't have any contraindication for succinylcholine like hyperkalemia or malignant hyperthermia. And if you still want to use rocuronium to break the laryngospasm, you can go ahead with laryngospasm in a dose of 1.2 mg per kg or more and monitor your patient with a nerve stimulator, but keep in mind the onset will be slightly delayed. Alternatively, you can use other benzyl isocyanide agents like cisaltracorium or atracorium at a higher dose, but again the onset will be delayed. Always try to find out any other underlying cause for your laryngospasm like conditions. Laryngospasm can mimic many other conditions. Now, the expanded use in critical care. 2022 retrospective study in ICU shows that there could be a possibility of bradycardia. The percentage is very less, 9 to 10%, hypersensitive reactions of 4.4% and little bit of bleeding complications. But again, Sugammadex is much safer than other reversal agent. Enhanced recovery of surgery, a 2025 study in patients undergone anterior cervical spine fixation, they found that the hospital stay is reduced by 6.2 days. It's very important because one hospital bed might cost around 20,000 rupees. In an average hospital might go up to 50,000 rupees. So, a 0.62 day decrease in hospital stay is a huge economical benefit not just to the patient but to the country also. So, the take home message, it's not just about the Sugammadex. Preventing residual neuromuscular blockade is paramount to reducing unwanted patients' adverse event in the perioperative period. You should have a thorough evaluation of patient's history, medication, treatment of the reversible condition which could help to prevent residual neuromuscular blockade. The second point is very important. The patient should be evaluated for the actual need of neuromuscular blockade. Not all patients undergoing general anesthesia need neuromuscular blockades. Neuromuscular blockades are basically administered to facilitate intubation and to facilitate surgical relaxation. So, not all patients need neuromuscular blockades. You can put a supraglottic airway device and do the surgery without using a neuromuscular blockade. And if you want to use a neuromuscular blockade, we'll go to the third point, should be using a neuromuscular blockade with a short duration of action and in the minimal amount which is really needed to produce neuromuscular blockade. Lastly, recent literature suggests Sugammadex is superior compared to Neostigmine in reducing residual neuromuscular blockade and particularly at moderate to deep forms of neuromuscular block. And the American Society of Anesthesiologists in their practice guidelines suggest to use a quantitative neuromuscular blocking monitoring to facilitate to decide about the dose and time of administration of Sugammadex. Thank you.
Thank you, Dr. Biju, for that, for enlightening us regarding the judicious use of Sugammadex. And I think if there are any questions in the audience, any comments, that is a wonderful talk.
Thank you, sir. Now I request Dr. Vijish to please come onto the stage to felicitate Dr. Biju. Now, I invite Dr. Binil to please come to the stage to felicitate Dr. Vijish.